Welcome to the Deep Dive. Today we're tackling, well, a cornerstone text, the Mood Disorders chapter from Kaplan and Sadock's comprehensive textbook of psychiatry.
It's definitely dense material.
Right, but our goal here is to kind of cut through that, give you a clear path through the core concepts, the history, the treatments, all without getting bogged down in jargon.
Exactly. And we should probably start right at the beginning with the name itself. The field has shifted.
Away from affective disorders.
Yeah. The preferred term now is mood disorders, and it's not just semantics.
Okay, why the change? What's the real difference between mood and affect in this context?
Well, affect is more like the weather, you know? It's
Right.
the immediate expression, what you see on the surface, and it changes quickly. Mood is more like the climate. It's a sustained emotional state lasting weeks, even months. It's a fundamental shift from someone's baseline.
So it's about duration and depth. We're talking about syndromes like major depressive disorder, MDD.
MDD, bipolar 1 and 2, persistent depressive disorder, what used to be called dysthymia, and cyclothymic disorder. Those are the big ones.
But the textbook immediately pushes beyond just those neat categories, doesn't it?
Yeah.
It talks about this spectrum reality.
Oh, absolutely. It makes a strong case that the official diagnoses are just the most severe points on a much wider spectrum.
So how wide are we talking?
Well, the stats are pretty striking. Severe disabling mood disorders hit maybe 5 to 8% of people.
Which is already a lot.
It is. But
Okay.
then you add in the milder subsyndromal conditions, brief episodes, or not quite meeting full criteria.
Oligosymptomatic, is that the term?
That's the one. When you include those, the lifetime rate, it basically doubles. And if you zoom out even further to all subclinical states, the textbook estimates up to maybe a third of the population experiences something on this spectrum at some point.
Wow, 1/3. That really reframes how common these experiences are. And you mentioned something about the bipolar spectrum specifically.
Yes, this is a huge point. Emerging data suggests possibly up to half of all mood disorders might actually fall somewhere on the bipolar spectrum, or BPS.
Half? That suggests a massive amount of underdiagnosis or misdiagnosis of bipolarity.
It really does. It means we need to be looking much more closely for signs of hypomania, even subtle ones. And then there's the comorbidity piece.
The overlap with other conditions.
Exactly. Particularly anxiety disorders. The text highlights a really strong link between bipolar 2 and things like panic disorder and OCD.
Which might point towards some shared underlying vulnerability, a common diathesis.
Precisely. It suggests the roots of mood and anxiety issues might be more intertwined than we used to think.
Okay, let's step back into history for a moment. It's kind of amazing that ancient thinkers were already grappling with this stuff. Melancholia and mania.
They definitely were. The Greeks, with their humorous melancholia linked to dark humor, autumn, bad sleep, and mania as well, raving madness.
Basic descriptions, but they saw the states.
They did. But the really striking insight, the one that feels incredibly modern, came from Horatius of Cappadocia, around 150 CE.
What did he figure out?
He made the connection. He wrote, and this is pretty amazing, melancholy is the commencement and a part of mania. He saw the link, the cycle.
Wow, so he was describing mixed episodes in the cyclical nature almost 2,000 years ago.
Incredible, isn't it? He saw that the same person could experience both extremes, and the ancients also keyed into temperament, personality, predisposition.
Right, and the 4 temperaments. How do those line up with modern ideas?
Well, the melancholic temperament associated with black bile, they saw as brooding, dependable, maybe a bit prone to overwork. You can see the lines to dysthymia there, maybe even some creative aspects.
And the opposite.
The sanguine humor, excess blood, linked to the hyperthymic temperament, active, sociable, maybe taking risks. You can see the potential connection to mania risk there.
And cyclothymic temperament.
That was seen as inherent mood swings, intensity. Basically, a recognized precursor or subthreshold state for more serious bipolar episodes.
So the idea that personality traits could shade into illness isn't new at all.
Not at all. Which brings us to Emil Kraepelin, around the late 19th, early 20th century. His massive contribution wasn't discovering the states, but unifying them
Grouping all forms of melancholia and mania together.
into manic-depressive illness, based on what he observed.
And what was his core reasoning for that unification?
3 main things. 1, common heredity, it clearly ran in families. 2, a recurrent course episodes came and went, often with periods of wellness in between.
And the third?
Transitions between opposite poles, seeing mania pop up in someone with a generally depressive temperament or vice versa. He argued it was all driven by the same underlying illness process.
A very biological view. But then Adolf Meyer came along with a different perspective, psychobiology.
Exactly. It's a crucial counterpoint. Meyer emphasized the interaction between a person's constitution, their biology, and their life experiences, their situation.
So biography mattered just as much as biology for Meyer.
Pretty much. He stressed understanding the person's whole story. While Kraepelin's structured approach heavily influenced our diagnostic systems like the DSM, Meyer's thinking really underpins why we value psychosocial treatments and personal history so much today. It's about bridging the two.
Okay, let's shift to the lived experience, the phenomenology. What makes a mood morbid or pathological, different from just, say, deep grief?
A few key things according to the text. First, it's sustained weeks or months, not days. Second, it's often out of proportion to any obvious trigger or lingers long after a trigger is gone.
Damn.
And crucially, it's typically unresponsive to reassurance or positive events. It kind of takes on a life of its own and warps judgment.
One of the absolute core features discussed is anhedonia, loss of pleasure.
Yes, but it's important to understand it's often described as a painful loss. It's not just being bored with hobbies. In severe depression, it can be a devastating loss of feeling for partners, for children.
That sounds incredibly distressing for the patient.
It is. They suffer intensely from that emotional numbness. And that painful quality is part of what distinguishes it from, say, the flat effect you might see in schizophrenia, which is more of an absence of displayed emotion.
Another core feature mentioned is psychomotor retardation, that feeling of slowdown.
Right. Some see this as central to the pathology. Subjectively, the person feels inertia, like moving through molasses. They might even feel like time itself has slowed down or stopped.
And objectively, how does it manifest?
Clinicians see it. Reduced spontaneous movement, slumped posture, slowed speech, long pauses before answering. It's measurable, which makes it a key indicator.
Then there are the vegetative symptoms, the body's rhythms going haywire.
Correct. Big disturbances in appetite, sleep, sex drive. The textbook actually points to anorexia and weight loss as possibly the most reliable physical signs of severe melancholic depression.
And sleep.
The classic pattern is early morning awakening, waking up hours before usual and not being able to get back to sleep, often paired with matinal worsening, meaning the mood is at its absolute worst first thing in the morning.
So if someone presents with the opposite, sleeping more, eating more, maybe feeling worse later in the day,
that pattern, the reversal of vegetative symptoms, plus mood reactivity, meaning their mood lifts temporarily with positive events that cluster defines atypical depression.
and that should make a clinician think.
It should strongly raise suspicion for bipolar II disorder. It's a major flag because the treatment approach would be different.
Okay, let's flip to the other side of the coin.
Yeah.
Mania and hypomania. What's the essence of mania?
Acceleration, accelerated activity, thoughts racing, speech pressured. The mood is often expansive, overly positive, grandiose, or sometimes intensely irritable.
And insight.
That's the critical part. Insight is usually gone. The person often feels fantastic, better than ever, and doesn't believe they're ill. This denial leads to terrible judgment, impulsivity, recklessness.
And hypomania is the milder version.
Exactly. It's less severe, doesn't involve psychosis, and doesn't typically cause major functional impairment, though it can still lead to trouble. It's the key marker for bipolar II.
The DSM criteria mention a duration, right? Like 4 days.
Yes, DSM-5 requires 4 days for hypomania. But the text points to emerging, thinking that maybe the recurrence of episodes, even brief ones lasting just a day or two, might be more clinically significant than sticking rigidly to the duration rule.
Interesting. Now, a somber but crucial topic, suicide. The link is stark. 50 to 70% of suicides tied to mood disorders. What predicts risk best?
The textbook is very clear on this. Hopelessness. A profound sense of hopelessness is actually more predictive of eventual suicide than the depression diagnosis itself.
That's powerful. But there's a counterintuitive point about timing, isn't there? Something Kraepelin observed.
Yes, and it's vital for clinicians. The risk is often lower when someone is in the absolute pit of a severe retarded depression. They may lack the energy, the psychomotor drive, to act on suicidal thoughts.
So the danger zone is?
The danger zone is often when they start to improve slightly, when their energy and activity level begin to return, but the dark thoughts and hopelessness haven't lifted yet. That's when they might have the capacity to carry out a plan.
A critical period of vigilance for clinicians and families.
Absolutely. And it reinforces the need to ask directly about suicide. The text emphasizes, as does all clinical wisdom, that asking does not plant the idea. It often brings immense relief.
Okay, let's pivot to causes etiology.
Mm-hmm.
Genes, environment, biology. How does the textbook bring it all together in that final common pathway model?
It's an integrative view. You start with genetic vulnerability. Heritability for MDD is around 37%, maybe higher for women. For bipolar, it's significantly higher.
But genes aren't destiny.
Not at all. That vulnerability then interacts with stress, internal stress, external life events. And interestingly, the text notes new evidence suggesting a kind of gene-environment interaction where the genetic predisposition might actually lead someone to generate more stressful life events.
Like a feedback loop.
Sort of, and chronic stressors like unemployment or a bad marriage often seem more impactful than acute ones for major mood disorders.
So genes plus stress lead to?
They likely trigger epigenetic changes, alterations in how genes are expressed, and maybe subtle neuronal changes or loss, particularly in areas like the hippocampus involved in memory and stress regulation.
And that disrupts the brain systems.
Exactly. It throws regulatory systems off balance hormones like cortisol neurotransmitters. And that disruption manifests as the subjective feelings and physical symptoms of depression or mania. It's the final common pathway.
What specific neurobiology is getting the most attention now?
Well, fMRI studies consistently show differences. In depression, there's often an over-response in the amygdala, insula, and anterior cingulate when processing negative information.
Emotional processing hubs.
Right. And dopamine systems are heavily implicated. Reduced dopamine activity in key reward and motivation pathways, mesolimbic, mesocortical, seems strongly linked to anhedonia, loss of motivation, that psychomotor slowing.
And you mentioned glutamate and GABA earlier.
Yes, that's a major current focus. Moving beyond just the classic monoamines, there's huge interest in these faster-acting neurotransmitters, glutamate and GABA, and their role in regulating brain circuits, maybe even switching between different functional networks.
Which connects to newer treatments.
Precisely. The discovery that NMDA antagonists, like ketamine, can produce rapid antidepressant effects really bolsters the idea that these glutamate pathways are critical targets. It suggests mood disorders might involve problems in brain network flexibility.
Before we get fully into treatment, let's quickly touch on the main psychological models the textbook outlines.
Okay, 3 main frameworks that inform therapy. First, the classic psychodynamic view focusing on unconscious conflicts, often relating to loss and internalized anger, sort of anger turned inward.
Okay, second.
Second, Aaron Beck's cognitive model. This is huge. It focuses on the cognitive triad, negative views of oneself, the world, and the future, driven by negative automatic thoughts and underlying core beliefs or schemas. This is the foundation for cognitive behavioral therapy, CBT.
And the third.
Interpersonal theory, or IPT, developed by Kraepelin and Weissman. This focuses squarely on current relationships and social functioning. It sees mood episodes as often triggered by interpersonal problems like grief, role disputes, or major life transitions. And that's the basis for interpersonal therapy.
Right, so different lenses to understand the psychological distress. Now, let's talk treatment principles. What's the main goal today when treating an acute episode?
The goalpost has shifted. It's no longer just about response, feeling somewhat better. The aim now is remission, getting the person fully symptom-free.
Why is remission so important?
Because achieving full remission significantly reduces the risk of relapse and recurrence down the line. And for recurrent MDD, and especially bipolar disorder, the text emphasizes that maintenance treatment is often lifelong indefinite.
Okay, pharmacotherapy for MDD. What's the typical approach?
First line is usually SSRIs or SNRIs, not necessarily because they're dramatically more effective than older drugs like TCAs, but because they're generally much better tolerated, safer in overdose.
And if those don't achieve remission? Adjunctive strategies.
Yeah, adding something on. Second-generation antipsychotics, or SGAs, things like quetiapine or aripiprazole, have proven effective as add-ons for depression. But you have to watch out for side effects like weight gain and metabolic issues.
In the newer options.
Ketamine and its relative esketamine are major new tools, especially for treatment-resistant depression, because they can work very rapidly. Older agents like TCAs and MAOIs are still used, but typically reserved for tougher cases due to their side effect burden and dietary restrictions for MAOIs.
Now, bipolar treatment seems particularly tricky, partly due to that misdiagnosis issue you raised earlier.
It's a huge challenge. Remember, maybe 2/3 of people with bipolar disorder are initially told they just have depression, so aggressive screening for any history of hypomania or mania is step 1.
And the core principle for medication.
Treat the disorder, not just the current episode. You need medications that can stabilize the current mood state, whether it's depression or mania, and prevent future episodes. That's why mood stabilizers are key.
Like lithium.
Lithium is the classic, still very effective, but also drugs like valproate, lamotrigine, and certain SGAs like quetiapine or olanzapine are used for stabilization and maintenance.
What about antidepressants in bipolar disorder? Yeah. Are they avoided?
As monotherapy, yes, generally discouraged, especially in bipolar R, because they carry a real risk of flipping someone into mania or hypomania or inducing rapid cycling.
Rapid cycling being?
4 or more distinct mood episodes, depression, mania, hypomania, or mixed within a year. It's a particularly difficult to treat pattern. Lamotrigine is often mentioned as being potentially helpful here, especially for preventing depressive relapses.
So antidepressants might be used carefully as an adjunct?
Sometimes, yes, usually added to a mood stabilizer, but very cautiously weighing the risks and benefits carefully.
And throughout all this, psychosocial interventions are essential, right? Not just pills.
Absolutely critical. Therapy works alongside medication. CBT, IPT, family-focused therapy, FFT, they all provide vital support, help people understand and manage their illness, challenge negative self-beliefs, improve coping skills, and rebuild functioning.
Is there a specific therapy highlighted for bipolar disorder?
Yes, interpersonal social rhythms therapy, or IPSRT. It builds on IPT, but adds a strong focus on stabilizing daily routines, sleep-wake cycles, meals, social activity.
Why the focus on routine?
Because disruptions in social rhythms, especially sleep loss, are known powerful triggers for manic episodes. So IPSRT directly targets that vulnerability by helping patients maintain consistency.
So wrapping this up, this deep dive into the Kaplan and Sadock chapter really paints a picture of mood disorders as this complex spectrum, from subthreshold traits right up to severe episodes.
Definitely. And it underscores that it's this interplay of genetics, neurobiology, with increasing focus on systems like dopamine and glutamate and psychosocial factors like stress and relationships.
Which means effective treatment just has to be integrated. You need the biological treatments, the pharmacology, working hand in hand with psychosocial support like CBT, IPT, or IPSRT.
It's treating the whole person within their context. Moving away from simplistic single-cause explanations is probably the biggest takeaway.
Okay, so for a final thought, let's circle back to that idea of temperament we discussed earlier, melancholic, hyperthymic, cyclothymic traits.
Right, the predispositions.
If these traits can predispose someone to illness, but might also maybe confer certain strengths like the drive and energy of hyperthymia for leadership, or the meticulousness of a melancholic trait for detailed work, it raises a tricky question.
Which is?
Should therapy always aim to completely eliminate or dampen down these potentially risky temperamental traits? Or could a different goal be to help individuals understand their innate tendencies, harness the strengths, and develop robust coping strategies to manage the inherent instability, maybe finding life paths that fit them better?
That's a really profound question. It touches on the balance between treating illness and respecting individuality, maybe even finding value in what makes someone vulnerable, something to really mull over.
Indeed. Well, thank you for joining us on this deep dive through a truly foundational piece of psychiatric literature. We hope breaking down this chapter on mood disorders helps you navigate this complex but crucial area.
Absolutely. Until next time.